Let's talk about a very interesting topic now. That is the topic of intestinal obstruction or bowel obstruction. Now, this is usually an emergency, and these emergency abdominal scenarios are becoming quite common when they're asking clinical scenarios in the INI-CET exam, or whether it is the NEET or the next exam. So you should know about all the causes, and you should know how to manage a patient with intestinal obstruction also. Now, intestinal obstruction, as the name suggests, the bowel is getting obstructed. Now, the bowel can become obstructed in two conditions. You can either have a dynamic bowel obstruction, or there can be an adynamic bowel obstruction, right? So, dynamic and adynamic bowel obstruction. Dynamic bowel obstruction means that there is a physical obstruction to the flow of feces. There is a physical obstruction to flow of feces, right? In adynamic obstruction, there is no physical obstruction. There is no physical obstruction, but bowel wall is not contracting. But bowel wall is not contracting, and that is the cause of obstruction then, right? So dynamic bowel obstruction, basically what happens, if this is the bowel, and this is proximal and this is distal, you will have some object physically obstructing the passage, and this obstructs the flow of feces, okay? Whereas if you have adynamic bowel obstruction, there is no physical obstruction, but the bowel wall is not contracting, and that is adynamic obstruction, okay? So let me give you two examples, two practical daily life examples, and that would help you understand and differentiate dynamic and adynamic bowel obstruction easily. So example number one is that your class gets over, your college class gets over, you have a car or a two-wheeler and you go and sit on that, and as soon as you go out of the college gate, you see that there is a procession, a wedding procession or a political party procession going on, and they are obstructing the road. And because of that physical obstruction of the road, you cannot move ahead. Right, so somebody is actually blocking the road, and that is why you cannot move. That is dynamic obstruction. But your car is working normally. You have the capacity to move, but you cannot move because of the obstruction. Adynamic obstruction, on the other hand, is that it is night time. You finish your studies in the library. You sit in your car or your bike. You're going out of the college, but suddenly the car battery dies or your scooter battery dies, and your scooter or car stops working. So now the road is empty, there is nobody there at night, but your car battery is dead and you cannot move. That is adynamic obstruction, right? Let's come back to situation number one. When we are stuck in a traffic jam, when a wedding procession or a political party procession is blocking the way, we get frustrated. And when we get frustrated, what is the favorite thing to do in our car? We blow the horn, right? Similarly, the proximal bowel contracts vigorously to overcome the obstruction. It contracts vigorously to overcome obstruction. And when it contracts vigorously to overcome the obstruction, it is going to create noise. So there will be hyperperistaltic bowel sounds. There will be hyperperistaltic bowel sounds here in dynamic obstruction. In adynamic obstruction, bowel is not contracting. You cannot blow the horn because your battery is dead. Bowel is not contracting. So you will have a silent abdomen to start with only. So I hope you can appreciate the difference between the two. In adynamic, there is a silent abdomen to start with. In dynamic obstruction, there are initially hyperperistaltic bowel sounds. Now, there are hyperperistaltic bowel sounds initially, but if the obstruction persists for a long time, if for long time obstruction persists, there can either be a perforation or there can be strangulation. And if there is a perforation or a strangulation, in that case, there is a silent abdomen. So another statement which I want you to remember for the exam, I want you to remember that initially there are hyperperistaltic sounds in dynamic obstruction, but a silent abdomen in dynamic obstruction, A silent abdomen in dynamic obstruction is an ominous sign because it suggests that either a perforation or a strangulation of the bowel has developed. So these are the key differences between dynamic and adynamic bowel obstruction. I will discuss the causes of each one of them in detail, but first I want to tell you the clinical features which are common to both of them, right? So bowel obstruction, there are certain cardinal features which are common to both types. So what are the cardinal clinical features of obstruction? The cardinal clinical features of obstruction are pain, which can be colicky abdominal pain. There can be abdominal distension. There can be abdominal distension. These patients can have vomiting, and there is non-passage of flatus and feces, non-passage of flatus and feces, and this is known as obstipation. Mind you, constipation is when there is just non-passage of feces. If there is non-passage of flatus and feces, then we call it obstipation. Now, these four are the cardinal clinical features which would be there in most of the patients with bowel obstruction. But one more thing which I want you to remember, the order of appearance of these symptoms, the order of appearance of these symptoms varies according to the site of obstruction. So for example, if there is a duodenal or a gastric obstruction, vomiting will be an early feature, right? Vomiting will be an early feature, but distension would be a late feature. But look at this patient. Here distension is an early feature. So distension will be an early feature if the colonic obstruction is there or distal obstruction is there. Then distension would be first and then it would be followed by vomiting. So the order of appearance of these symptoms can vary according to the site of obstruction, but the clinical features pretty much remain the same. So let's discuss a scenario. We have a patient, this patient only. We used to get a lot of these patients in the emergency, at least 4 or 5 bowel obstructions each emergency used to come. So such a patient comes to the emergency and you are the intern. The postgraduate asks you that what do we do in this patient? How do we work up this patient? So the workup of a patient with bowel obstruction, the initial investigation, what will be the initial investigation in these patients? This question has been asked many times in the exam. This is X-ray abdomen, erect and supine. X-ray abdomen, erect and supine are the initial investigations in patients with bowel obstruction. You should remember this. So let's look at these X-rays and see what do we find in them. Now, if you look at an erect X-ray, in an erect X-ray, we are going to get air fluid levels. Right? Normally, there are 3 air fluid levels which can normally be seen. So, if more than 3 air fluid levels are there, that is when we say that the patient has obstruction. If more than 3 air fluid levels are there, then that is when we say that there is obstruction. And one more thing which you should remember, more the levels, more distal is the obstruction. More the number of air fluid levels, more distal is the obstruction. This is another line which you should know. And erect X-ray would tell me if obstruction is present or not. If obstruction present or negative, but it does not tell us not the site. It does not tell me the site of obstruction. So please remember this, right? These are the points which you need to remember. They have been covered by Dr. Mayur in his videos as well. To know the site, we need to do the supine X-ray. S is for supine, S will tell me the site. And how do I get to know the site? Look, supposing there is an obstruction here, so the bowel proximal to it will dilate, right? and the bowel distal to this, will be constricted. So that bowel I won't be able to see, whereas the bowel which dilates, I will be able to make out its features. So in a supine film, jejunum, let's look at the jejunum. The jejunum, you get the concertina effect. You get the concertina effect or the step ladder pattern. It is arranged in the form of a step ladder, and you will get complete volvulae. You will get complete volvulae. You can see here, this is the jejunum, and you can see these complete volvulae going from one wall to the other, and it gives it a feathery appearance. It gives it a feathery appearance. So these are the features of jejunal loops. Ileal loops are known as featureless loops of Wangenstein. They don't have any classical feature. These are known as the featureless loops of Wangenstein. What about the large bowel? What are the features of large bowel on a supine X-ray? So large bowel will be seen in the periphery of the film. These X-rays are also asked in the viva of final year students, so you should know all these points. Large bowel will be seen in the periphery, and you will see hostrations. Hostrations, unlike volvulae, are incomplete. So look here, this is one wall, this is the other wall, and can you see these hostrations? They are incomplete in comparison to volvulae, which were going from one wall to the other. So this is how you differentiate small bowel obstruction from large bowel obstruction. One more thing on an X-ray you should remember is the 369 rule. So the diameter of small intestine of 3 centimeters on an X-ray, that is the diameter of obstruction or a dangerous diameter. 6 centimeters for large intestine is the dangerous diameter or obstructive diameter, and 9 centimeters for cecum. If the cecum reaches 9 centimeter size, that means it can perforate anytime. So that is the critical diameter. So you remember the 369 rule as well. So the initial investigation in bowel obstruction, I've told you, is X-ray abdomen erect and supine. But what is the investigation of choice? This has also been asked multiple times in the exam. The investigation of choice for bowel obstruction in adults is CECT, whereas in children, the investigation of choice is ultrasound. CECT is contrast enhanced CT scan, that is the investigation of choice in adults, and children it is ultrasonography, right? So these are the investigations which are done in patients with bowel obstruction. Again, how do we manage, now that we know that the patient has bowel obstruction, how do we manage these patients? So management of these patients, you need to know that first we need to give these patients IV fluids. We need to give them IV fluids because these patients are usually dehydrated. They are usually dehydrated and they have third space loss as well. So we need to give IV fluids, and the best IV fluid which can be given is ringer lactate. Right? We need to put in a nasogastric tube. We need to put in a nasogastric tube or a Ryle's tube. This I've covered in detail in the nutrition chapter. Ryle's tube, how to insert the Ryle's tube, how to measure the length, that is from the angle of mouth to ear lobule to xiphisternum. It is put usually in the sitting position with the neck slightly flexed. And how do we know whether the Ryle's tube is in the right position? All these points which have been asked in the exam, I've covered in the chapter on nutrition. So Ryle's tube or nasogastric tube is being put in to decompress the system. To decompress the system, and you need to know this abdominal distension which the patient has. This abdominal distension which the patient has, majority is due to swallowed air. So this is another question which you should know. Majority is due to swallowed air, that forms the bulk of why distension occurs, and other is because of fluid getting retained there as well. So we put in a nasogastric tube, we give IV fluids, give IV antibiotics to these patients for gram-negative cover and for anaerobes painkillers. Painkillers are also given in these patients, and we need to monitor these patients, right? And we need to monitor these patients. Now, when we are monitoring these patients, if patient improves, there are certain conditions which can resolve spontaneously. If the patient improves, good for us. If the patient does not improve, then we need to take up the patient for surgery, and surgery is, exploratory laparotomy has to be done. So we need to carry out an exploratory laparotomy in these patients. Now, when we do an exploratory laparotomy, this is another very important question which is asked in the exam, and whenever I used to operate a patient with intestinal obstruction, either it used to be my junior postgraduate, or sometimes interns also used to assist, and this was the first question I used to ask them, that when I open the abdomen, which is the first structure I want to look at in a patient with bowel obstruction? And this same question was even asked in the AIIMS exam 3 years back. The first structure when we do exploratory laparotomy, the first structure which we look at is the cecum. Right? Now, if the cecum is collapsed, then it is small intestinal obstruction. But if the cecum is distended, I know it is a large intestinal obstruction. Right? That is why we look at the cecum first. Please remember this point, and that is how we can decipher whether we are dealing with a small intestinal or a large intestinal obstruction. Now, another thing, when we open up the abdomen, we've looked at the cecum first, but we also need to assess whether the bowel is viable or non-viable. So, how do we know if the bowel is viable or non-viable? What are the features which we need to look at? So, if it is viable bowel, the bowel will be healthy, pink in color. It will be healthy pink in color, whereas non-viable bowel will be dusky. Non-viable bowel will be dusky, black in color. Mesenteric pulsations, so the vessels mesenteric pulsations will be present. Mesenteric pulsations will be present. Here they would be absent. And when we stroke or we stimulate the bowel, if we stimulate the bowel, we just stroke it gently, then peristalsis will be seen in if there is this viable bowel, and no peristalsis if it is non-viable bowel. Right? So this is how we differentiate between the two. Now, non-viable bowel or strangulated bowel, there are certain clinical features before we open up the abdomen also which can hint towards a strangulation. Strangulation means the blood supply is not going to the bowel. So what are the clinical features which can tell me that there is strangulation even before I open up the case? So there will be increased abdominal pain, not getting controlled by medicines. There will be increased total leukocyte count. The patient will be febrile. There will be fever. Of course, CT also, there are two findings which will tell us whether patient has a strangulation or not. So on CECT, there are two findings which you should know about. If there is reduced bowel wall enhancement, on CECT, then 11 times higher, then there is a 11 times higher chance of strangulation. Higher chance of strangulation is there. So please remember this. This is written in Bailey very clearly. Reduced bowel wall enhancement, 11 times higher chance of strangulation is there. And the second sign is if there is absence of mesenteric fluid. If there is absence of mesenteric fluid, then it reduces the chance by 6 times. Then it reduces chance by 6 times that the patient has strangulation. So these are the features, clinical features and CT findings which would tell us if strangulation is there or not. Also, I have told you how to differentiate between viable and non-viable. Now, this was the general management. Now we have to talk about individual conditions which give rise to bowel obstruction. And first we are going to talk about dynamic bowel obstruction. First we are talking about dynamic bowel obstruction. In dynamic bowel obstruction, the first one which we're going to talk about are bowel adhesions. Are adhesions or adhesive intestinal obstruction. You need to know that this is the most common cause of obstruction overall. This is the most common cause of obstruction overall, and it is the most common cause of obstruction in the small intestine also. So in the small intestine and overall, adhesions are the most common cause. If you're specifically asked what is the most common cause of obstruction in large intestine, if the question is very specific that what is the most common cause of colonic obstruction, then the answer is tumors or cancer. But otherwise, overall, bowel adhesions are the most common cause of bowel obstruction. Now, these adhesions can mainly be formed post-surgery. So, majority of the adhesions are formed post-surgery. But this is no rocket science. Everyone knows that adhesions can form post-surgery. But what the examiners have asked in the exam are what are the non-surgical causes of bowel adhesions. Non-surgical causes of bowel adhesions. These have been asked multiple times in the exam. And the non-surgical causes of bowel adhesions in our country, when you can't think of anything else, think of TB, tuberculosis. The counterpart in the Western world, Crohn's disease. Crohn's disease, which is an inflammatory bowel disease, which I have covered. Other causes, another very common condition in our country, pelvic inflammatory disease, PID, pelvic inflammatory disease. Endometriosis can also give rise to these adhesions. And post-radiotherapy. Post-radiotherapy for some tumor, supposing the patient is getting radiotherapy for cervical cancer or endometrial cancer, that can also induce adhesions in the bowel. So these are the non-surgical causes which you need to remember. Commonly they are seen following surgery. And what do bowel adhesions look like? Let's just look here. This is what bowel adhesions look like, and they can give rise to obstruction. Now, if we talk about the clinical features, the clinical features are the same cardinal signs of obstruction which we have discussed. Patient will come with obstipation, distension, pain and vomiting. That is how the patient presents. The initial investigation is X-ray abdomen erect and supine. And the investigation of choice is CECT. Right? The investigation of choice is CECT. Of course, if there is a scar over the abdomen and the patient has come with adhesions and the patient has come with obstruction, your first thing which your mind goes to are adhesions. And you should also know that adhesions can form many years after surgery as well. For example, I had an appendectomy when I was in class 7, and at approximately the same time my cousin in America also had an appendectomy. Now my appendix was fine, it did not perforate. Her appendix perforated, so hers was a more complicated surgery, and post the surgery she developed adhesions, but they manifested after 2 years. She had an attack of subacute intestinal obstruction. So it can occur many years after surgery also, these adhesions can manifest. That is another thing which you need to know. Now the management of these patients is the same. We need to give IV fluids, we need to give put a nasogastric tube, IV antibiotics are to be given. One more thing which you need to know here is a gastrographin study. So gastrographin is a water-soluble contrast. A gastrographin study can sometimes help in overcoming this adhesive intestinal obstruction. So some people like to do gastrographin studies in bowel obstruction as well. Now, one thing which you need to remember, that there is a line written in Bailey, and this is a very famous line written in Bailey, that you should never allow the sun to rise and set on a patient with dynamic bowel obstruction. So basically, what the author is trying to say, that you should operate patients with dynamic obstruction early so that strangulation does not develop. That's what the author is trying to convey. But the only exception to the rule is bowel adhesions. So bowel adhesions or adhesive obstruction patients can be managed conservatively for 48 to 72 hours. So this is the only dynamic obstruction where we are trying conservative management. Of course, I've highlighted we'll give IV fluids, we'll decompress, give antibiotics, give painkillers, but conservative management can be tried for 48 to 72 hours. Now, the reason why I'm doing this, there are two reasons why I'm doing this. Reason number one is that majority of the adhesive obstructions resolve spontaneously. Majority resolves spontaneously, right, with conservative management. And the second reason is that if I cut these adhesions, again more adhesions will form. So the more number of times I do the surgery, more and more adhesions will keep on forming, and it will just complicate things for me in future. If patient improves, no surgery. But if the problem persists, then we need to carry out surgery. And what will be the surgery for bowel adhesions? Look here, I need to cut these adhesions. Which are here. So the surgery is known as adhesiolysis. Right? So adhesiolysis will be done. In Bailey it is written that if recurrent adhesive obstruction is there, then in the olden days 2 surgeries were performed. Nowadays we don't do this. If recurrent adhesive obstruction is there, we can do Nobel's plication, or we can do Charles-Philippe procedure. These are the 2 procedures which have been mentioned in Bailey for recurrent adhesive intestinal obstruction. So this was the first cause of dynamic bowel obstruction, that is adhesive intestinal obstruction. The next one which we need to talk about are bowel atresias. That means the bowel continuity is not there. And atresias, you would, of course, it is common sense that they would present in children, because if the continuity of bowel is not there, it is going to present early. And the first one which we're going to talk about is duodenal atresia. So duodenal atresia, it is a common cause of neonatal bowel obstruction. And these patients are going to present, what will be the clinical features? These patients are going to present at birth. And because the duodenum is obstructed, there is going to be bilious vomiting. Present in these patients at birth. And these 2 points help in differentiating it from idiopathic hypertrophic pyloric stenosis, which I've told you that is going to manifest after 3 to 4 weeks, and usually there is, and in those patients there is non-bilious vomiting. Okay. Now these patients with duodenal atresias, it can be associated with a Down syndrome, and the mother who's carrying such a child might have polyhydramnios. So it can even be detected in the prenatal scan. Sometimes if the mother has polyhydramnios and you investigate, even in the prenatal scan, you can pick up an atretic bowel. Now, duodenal atresia, it can be of 3 types. There are 3 types of duodenal atresia. Type 1 duodenal atresia is the most common. Type 1 is the most common type of duodenal atresia. This has been asked in the exam. This is when there is just a mucosal web there, and this is also known as a windsock deformity. This is also known as a windsock deformity. So basically what happens, that this is the duodenum, right? There is just a mucosal barrier between the two loops. There is no discontinuity, just a mucosal barrier. There is no gap there or no fibrous tissue there. This is type 1, which is the most common. Type 2 is when there is a fibrous band between the two loops. When there is a fibrous band which is present between the two loops. So this is one loop, then there is a fibrous band, and then there is another loop, but muscle continuity is there. But muscle continuity is present. And type 3 is when there is a gap present. Type 3 is when there is a gap between the two. So there is an actual gap which is present, that is type 3. This is the most severe, when there is an actual gap present there. Now, if we do an X-ray in these patients, we've already discussed that the initial investigation is an X-ray. And if we do an X-ray in these patients, we will see a double bubble sign, right? So if we do an X-ray in duodenal atresia, we will see a double bubble sign, one bigger bubble of the stomach and smaller of the duodenum. Now, double bubble sign, this is a classical sign asked many times in the exam. So double bubble sign is what you're going to see, but you can even see a double bubble sign. You can see it in duodenal atresia, or you can see it in annular pancreas, or you can see it in annular pancreas as well. Annular pancreas has been covered in the pancreas module, the benign module, and in that the pancreas encases the duodenum and causes duodenal obstruction. So the investigation of choice is going to be a CECT or an ultrasound. That is what will differentiate whether it's a duodenal atresia or annular pancreas. The management is going to be surgery in both the cases, and the surgical treatment for both these conditions I've highlighted. DD is better than DJ. What do we mean by this? Duodenostomy is a better procedure than duodenojejunectomy. Please remember this. This has also been asked multiple times. Duodenojejunectomy is a better procedure than duodenojejunectomy. Talking about atresias, we should also know about jejunal atresia. Now, jejunal atresia is actually more common than duodenal atresia. This is more common than duodenal atresia. And patients with jejunal atresias, it can be associated with cystic fibrosis. It can be associated with cystic fibrosis. It can also be associated with malrotation of gut. And these patients also, the clinical features, they are going to come with a distension, vomiting. They will come with distension. They will come with bilious vomiting. Right? So in these patients, when we do an X-ray, the initial investigation is X-ray. For jejunal atresia, when we do the X-ray, we get the triple bubble sign. Duodenal atresia, it was double bubble. Here it is triple bubble sign, stomach, duodenum and jejunum, 3 bubbles you're going to see. This helps in differentiating. Of course, the investigation of choice would be an ultrasound or a CT to exactly know what is the cause. Now, the types of intestinal atresias, there can be 4 types of intestinal atresias, right? Type 1 intestinal atresia is when there is just a mucosal atresia. So, type 1 is when there is just a mucosal atresia. Type 2 is when there is a fibrous band between the two. Type 3A. 3A is when there is a wedge of mesentery, right? When there is a single V-shaped mesenteric defect, when there is a single atresia and you have a V-shaped mesentery. So there is a defect in the mesentery as well. There is a V-shaped mesentery, that is type 3. Type 3B. Type 3B is when there is complete jejunal atresia. When there is complete jejunal atresia and there is a coiled ileum. Coiled ileum, and this appearance is known as the Christmas tree appearance. This has also been asked in the exam. Christmas tree appearance of jejunal atresia is type 3B. This has been asked multiple times in the exam. And finally, type 4 is when there are multiple atresias, and this gives rise to the sausage appearance, right? You can see here, because of these multiple atresias, you get these multiple sausage-like appearances. So this also is known as the sausage appearance. You should know this. This has also been asked in the exam. So these are the various types of atresias which you should know: sausage appearance, coiled up appearance, or Christmas tree appearance. The management of jejunal atresia is resection and anastomosis. You resect the atretic portion and you anastomose the two ends. The details of bowel anastomosis, I've already covered in the general surgery modules where I spoke about sutures and suturing procedures. So this is regarding jejunal atresia and duodenal atresia, which I've covered. Another type of dynamic bowel obstruction which is seen in children or neonates is meconium ileus. So next we'll talk about meconium ileus. So meconium ileus is one of the most common cause of neonatal bowel obstruction. One of the most common causes of neonatal bowel obstruction is meconium ileus or meconium plug syndrome. They both are slightly different, but you can remember that meconium plug, if it is given, is the best answer. It is one of the most common causes of neonatal bowel obstruction, meconium ileus. And meconium ileus usually occurs if there are thickened secretions. If there is thickened meconium, and thickened meconium can be associated with patients with cystic fibrosis. And the clinical features, these patients will present with non-passage of meconium. Now, all of you who've taken deliveries in the labor room know that when the child is born, within a few hours they usually pass meconium. But if for a day or so they don't pass meconium, then we start getting worried. And non-passage of meconium, if it's there, one of the things which you need to consider is a meconium ileus. Of course, you should rule out conditions like anorectal malformations and Hirschsprung's disease as well. So non-passage of meconium, there will be abdominal distension also, which will be seen in these children. Now, if you do an X-ray, we know that X-ray is the initial investigation. Now, if X-ray is done in a patient, that is the initial investigation, then we are going to get a soap bubble appearance. This is your soap bubble appearance. Soap bubble appearance would be seen, and this is also known as Neuhauser sign. You'll get the soap bubble appearance. This is also known as the Neuhauser sign. And you can even get microcolon. Because the fecal matter or the meconium is not moving forward. Now, if we are suspecting cystic fibrosis in these patients, we can even do a sweat chloride test. And the management of these patients with meconium ileus. So initially all these patients used to require surgery, but they realized that gastrographin enemas, I told you gastrographin is a water soluble contrast. So gastrographin enemas are the first line of treatment and they help in resolving majority of the cases. They help in resolving majority of the cases. The meconium can be passed, but if it does not work, then these patients require surgery, and the surgery which is done is known as the Bishop-Koop surgery. It is known as the Bishop-Koop surgery, in which we create an end-to-side ileoileostomy, end-to-side ileoileostomy, and we have an ileostomy here. This ileostomy is basically used for irrigation. We will irrigate from this ileostomy, and irrigation through this ileostomy helps in clearing out the meconium, the thickened secretions which are there. They help in clearing those out. So these are the common causes of dynamic bowel obstruction which we can see in children. So we've discussed till now, we've discussed about duodenal atresias, jejunal atresias, and I have told you about meconium ileus as well. Now another cause of bowel obstruction in children can be a Ladd's band. And what exactly is a Ladd's band? Ladd's band is the most common intestinal malrotation abnormality. It is the most common intestinal malrotation abnormality, in which what happens that you have an abnormal band which is running from the right hypochondrium. So you have a band running from the right hypochondrium, below the liver, right hypochondrium below the liver to the cecum. And when this band runs from below the right hypochondrium to the cecum, what it is going to do is that it will compress the duodenum from outside. It will compress the duodenum from outside, giving rise to intestinal obstruction. We've already discussed the clinical features of intestinal obstruction. We've discussed the workup of intestinal obstruction multiple times. I'm not repeating that. So it compresses the duodenum from outside, gives rise to duodenal obstruction. Patient can again come with bilious vomiting, and the management in this case is surgery, and the surgery is excision of the Ladd's band. Is excision of Ladd's band, right? So till now in dynamic bowel obstruction, we've covered adhesive obstruction, which is the most common cause, and we've covered all the causes of dynamic obstruction in neonates and young children, which includes atresias. We've spoken about Ladd's band, and we've spoken about meconium ileus. Now the next type of intussusception, next cause of dynamic intussusception which we need to discuss is intussusception. Now intussusception is telescoping of one bowel loop. This is a very important topic. It is telescoping of one bowel loop into other. One bowel loop into other is intussusception. And in intussusception, usually what happens that the proximal bowel is going to go into the distal bowel. So you can see here that the ileum is going into the colon, and the loop which goes inside is known as the intussusceptum. This is the loop which is going inside. This is the intussusceptum. And the receiving loop, the loop which receives, the receiving loop is known as the intussuscipiens, right? Two more points which I want you to understand from this diagram. Point number one is that the neck of the intussusception, neck is the narrowest portion of the intussusception. Neck is the narrowest portion of the intussusception. But when the neck is the narrowest and vessels are getting compressed here, which one will be the first portion to undergo ischemia? Will it be the neck or will it be the apex here? Yes, correct. So the apex is the most common. Apex is the most common site for ischemia. Or the first site also is apex, and the most common is also apex, because the vessels are getting compressed here, and then the apex will be the one which will be affected. So remember these 2 points also in intussusception. Now intussusception can be of two types. You can either have primary intussusception, or intussusception can be secondary to a pathological lead point. Can be secondary to a pathological lead point. What exactly does that mean? I'll just explain to you. So primary intussusception is usually seen in children. It is seen in children between 6 months to 2 years of age, and the proposed mechanism behind primary intussusception, is hypertrophy of the Peyer's patches. As the immune system is developing in these children, there can be hypertrophy of the Peyer's patches. Hypertrophy of Peyer's patches, which is the lymphoid tissue present in the bowel, and that can trigger intussusception. Okay. Now, primary intussusception is predominantly ileocolic. That means the ileum going into the colon. This is the most common overall as well. And you need to remember that primary intussusception is much more common than a secondary lead point, and ileocolic is the most common overall intussusception. Okay. So this is regarding primary intussusception. Secondary intussusception, on the other hand, can be secondary to a pathological lead point. What exactly does that mean? If you see the diagram here, supposing this bowel had a lesion here, and that lesion triggered the intussusception, that lesion caused the intussusception, that is known as a secondary lead point. Okay, that is known as a secondary lead point. So this can be seen in both adults and children. It is secondary to a lesion. Now this lesion in adults, the most common secondary lead point is a polyp. The most common is a polyp. Others can be a diverticulum. Meckel's diverticulum can also give rise to this, or a tumor can also give rise to this. In children also it can be a polyp, it can be lymphoma, which can trigger a secondary intussusception in children as well. And secondary intussusception is usually colocolic. Colon going into the colon, colocolic, but I've already told you ileocolic is more common than colocolic. Secondary intussusception can be recurrent because the pathological lead point will again and again cause intussusception. Now, the clinical features of intussusception are like bowel obstruction. So we know the patient is going to come with distension. We know the patient will have vomiting. The child can have pain, and the child of course cannot complain of pain, but what they usually do is that they draw up legs. They draw up the legs and they cry at that time. They cry inconsolably. Even if you try to console the child, you can't console the child, and they draw up the legs during these episodes of intussusception. And of course, there can be non-passage of flatus and feces. So that is how we suspect a patient has bowel obstruction. The initial investigation is X-ray abdomen. And the investigation of choice, we know that in children it is USG, and in adults it is CECT. Right? Now, when an ultrasound is done in children, what are the ultrasound findings which you get? These two signs are very important. You get the donut sign. So you will get one bowel loop. And you will have another bowel loop inside it. This is known as the donut sign or the target sign. Donut or target sign. Or you can get the pseudo-kidney sign. This is the pseudo-kidney sign, and you will see the presence of mesenteric vessels. Mesenteric vessels within the bowel loop. Within bowel is again a telltale sign on ultrasound. The investigation of choice is CECT. Now, you need to understand one thing. What is happening here is one loop has gone inside another loop, right? One loop has gone inside another loop. And if we give enema from here, if we do a contrast enema, what appearance will you get? So another investigation is a contrast enema, and when we do the contrast enema, you can see here you will get a claw sign or a pincer sign. So here you get a claw sign or a pincer sign, right? Let's talk about the management of intussusception now. The management of intussusception. Before I tell you the management, I just want to share a story with you. So in college, table tennis was one of the favorite sports which we all used to play. There was a table tennis table in the recreation room, and all of us used to play a lot there. And sometimes it used to happen that there was just a single ball and a tense match was going on, but somebody accidentally stepped on the ball and the ball got squished from one side. Now, if such a situation was there and we wanted to finish the match and all the shops were closed, there was only one way to fix the ball. And that way to fix the ball was to put it in hot water. I'm sure a lot of you must have also tried this, that if you put a squished ping pong ball into hot water, then the gas inside the ball is going to expand and it's going to pop back into position. You must be wondering that why am I telling you this story here? Well, a similar principle also applies to the management of intussusception. I told you a contrast enema is going to show you a claw sign or a pincer sign. But because of the contrast and the water, contrast plus water, because of the pressure of the contrast and the water, it can push the bowel into normal position. It can push the bowel into normal position. So what you need to understand is that contrast enema is both diagnostic and therapeutic in intussusception. Is both diagnostic and therapeutic in intussusception. So it is both therapeutic and diagnostic and therapeutic in intussusception. Then what are the indications to carry out surgery? Indications for surgery, and if we do surgery, it is going to be resection and anastomosis. The indications for surgery are going to be if there is recurrent intussusception, if once it has been reduced but again it is occurring, recurrent intussusception, you need to do surgery. If there is a secondary pathological lead point, then it will keep on occurring again and you need to deal with it surgically. If there has been a perforation or the bowel is strangulated, these are the 4 conditions when we need to carry out resection and anastomosis in intussusception. Now, up till now I was telling you that intussusception is proximal going into distal, but there is one situation where there can be retrograde intussusception as well. Retrograde intussusception, it is quite rare. I highlighted this in the stomach module. Retrograde intussusception, this is when distal to proximal, right? Distal bowel loop goes into the proximal bowel loop. That is retrograde intussusception, and this can rarely be seen in patients with Roux-en-Y gastrojejunostomy. If you remember the Roux-en-Y gastrojejunostomy, this was the stomach, this was the jejunum which was anastomosed to the stomach, right? And you had the duodenum. This was the duodenum which we had closed, and the other part of jejunum we anastomosed back with the jejunum, and this was your Roux-en-Y gastrojejunostomy. This, you know, is the Roux limb. This yellow one is known as the Roux limb, and this green one where the bile is coming was the biliary limb. Now, retrograde intussusception is if this jejunum this jejunum, which is distal, it undergoes intussusception into the biliary limb. So the distal jejunum undergoes intussusception into the biliary limb, that is called retrograde intussusception. This has not been asked in the exam till now, but it is good to know this fact. It can be rarely seen in patients with Roux-en-Y gastrojejunostomy. So that was regarding intussusception, which is an important topic from the point of view of the exam. Now you need to know that if you are operating a patient with intussusception, and no strangulation, if there is no strangulation and if there is no pathological lead point, and no perforation, then we can reduce the intussusception. And these two diagrams have been given in Bailey. When you have to reduce the intussusception, you start reducing from the apex of the intussusception, and you always press, you never pull, you squeeze, you never pull. So squeeze from the apex and gradually the bowel is going to come out. That is how you reduce an intussusception. But if any of these three things are there, strangulation, a pathological lead point or perforation, then we need to carry out a resection and anastomosis. The next cause of dynamic, we are still talking about dynamic bowel obstruction. The next cause of dynamic bowel obstruction is volvulus. You know, volvulus is when the bowel rotates along an axis, that is volvulus. And the two main types of volvulus which we need to talk about, sigmoid volvulus and we need to talk about cecal volvulus. Sigmoid volvulus is much more common than cecal volvulus. And sigmoid volvulus, the predisposing factors for sigmoid volvulus. Are a long and narrow mesentery. Of sigmoid. Redundant sigmoid. If you have a long redundant sigmoid, it can easily twist. And the third is a loaded sigmoid colon. So these are the three predisposing factors which can give rise to a sigmoid volvulus. A sigmoid volvulus usually rotates. It usually rotates anti-clockwise. And this can be commonly seen in patients who are suffering from psychiatric illnesses, who are on antipsychotic medications, so psychiatric patients who are institutionalized, so either in an asylum or in a jail. These institutionalized patients are also predisposed to these volvulus, right? So the clinical features of patients with sigmoid volvulus, you know that the obstruction is in the colon, and we have discussed that if the obstruction is in the colon, distension will be, there will be marked distension, right? There will be obstipation in these patients, that is non-passage of flatus and feces. Vomiting will be a late feature. And these patients are also going to have pain. Now the problem with sigmoid volvulus is that, look, if this is the sigmoid and it is undergoing volvulus, it rotates and it is going to rotate on its axis and the vessels are going to also get twisted. So there is obstruction occurring at 2 points. One point is here, another point is here. So this can give rise to a closed loop obstruction. Closed loop obstruction can be there, and strangulation is common. Strangulation common because the blood supply is also getting twisted. So this is something which you need to remember in these patients. So these are the clinical features. You know that the initial investigation The initial investigation in any bowel obstruction case is X-ray abdomen. And if you carry out an X-ray abdomen in a patient with sigmoid volvulus, you are going to get the coffee bean sign, or the bent inner tube sign. You will get the coffee bean sign or you get the bent inner tube sign in these patients. You can see here that this is the sigmoid and you can see that it is bent from inside. So you get the bent sign. Some people like to call it the omega sign as well. Now in sigmoid volvulus, if you do a contrast enema like we did for intussusception, if you do a contrast enema like we did in patients with intussusception, if you do a contrast enema in sigmoid volvulus, then you're going to get a bird's beak appearance. Or some people like to call it the ace of spade sign. The ace of spade sign, but bird's beak is more relatable. You can see here that it is tapered like a bird's beak. And this was a picture which I clicked in South Africa, and there was this family of ostriches, and the way they were standing, the male ostrich was the tallest, then the female ostrich, and then the offspring, and they were standing in in the order of their height, and I could get a side pose. So you can see the beak here also, it is tapered, and you get a similar sign here. You get the bird's beak appearance. Bird's beak appearance we were also getting in achalasia cardia. The investigation of choice, is CECT for any bowel obstruction. It is CECT for adults, ultrasound in children. Now coming to the management of sigmoid volvulus. The management of sigmoid volvulus. So management of sigmoid volvulus is, you have to divide it into two. You have to see whether the patient is stable. There are no features of strangulation or perforation. There are no features of strangulation or perforation. That is scenario number one. And scenario number two is that the patient is unstable or has sepsis, has strangulation or perforation. So these are the two situations which are there. Now in situation number one, if the patient is stable and there are no features of strangulation or perforation, what we do is sigmoidoscopic decompression. We take a sigmoidoscope. The sigmoidoscope length is around 60 to 90 centimeters. Sigmoidoscopic decompression is done. You decompress all the fecal matter and the gas, and the bowel comes back into normal position. But this is just the emergency management. This is just the emergency management. And another thing which I want to tell you here is that, when you are in the surgical emergency late at night, you don't have a sigmoidoscope available with you. And at that time, if you don't have a sigmoidoscope, what we usually used to do was to give the intern a flatus tube. And during internship, we've also done it. So it's not as if we were torturing the interns. We've also gone through the same phase. So a flatus tube was given to the intern, and the intern was told to take this patient to an isolated room and insert that flatus tube into the rectum. So what used to happen was that as soon as the intern used to insert that flatus tube, there used to be an explosive decompression. Large amounts of fecal matter and gas used to come out, and suddenly the patient used to get relieved, but the entire room used to stink, which is why we used to tell the intern to go to an isolated room and do this procedure. Of course, the better thing to do is a sigmoidoscopic decompression, which is the emergency management. But what is the definitive management in these patients? The definitive management, you need to understand that sigmoidectomy is a better treatment option than sigmoidopexy. That means just fixing the sigmoid, because sigmoidopexy has a high recurrence rate. Pexy means you derotate and you fix it. but it has a high recurrence rate, which is why sigmoidectomy is a better procedure to carry out definitive surgery in patients with sigmoid volvulus. Sigmoid volvulus is the most common volvulus in GIT. Now, if the patient has features of sepsis, strangulation or perforation, now what do we do? So look, this is the sigmoid, and there is a perforation here. Now, the abdomen is contaminated and we want to finish the surgery quickly. So in these patients, resection of the sigmoid and anastomosis is not an option. So here what do we do to finish the surgery quickly? We cut the perforated segment. We take out the proximal end. The proximal end of the sigmoid is taken out as a colostomy. Colostomies I've already covered in the benign small and large bowel module. And we close the distal end. Distal end is closed and kept inside the peritoneal cavity. Right? Once the patient recovers, then after 6 weeks, 6 to 8 weeks, we can anastomose the two ends. So this is Hartmann's procedure. This is known as Hartmann's procedure. You need to know the name. This has been asked many times. Hartmann's is not exclusive to sigmoid volvulus. It can be done in any condition of sigmoid where the sigmoid is perforated and there is contamination. So it can be done following trauma. It can be done if a sigmoid diverticula perforates. It can be done if there is a sigmoid cancer and the patient comes with obstruction. So this is our bailout procedure which we can do quickly, known as the Hartmann's procedure. This was the management of sigmoid volvulus. The other volvulus which you need to know about is cecal volvulus. So cecal volvulus now cecum is usually fixed. So cecum usually cannot undergo rotation because it is fixed. So cecal volvulus, usually it undergoes volvulus clockwise. It undergoes volvulus clockwise, and you need to have a mobile cecum or a cecal bascule. A cecal bascule is also a type of a mobile cecum. These are the predisposing factors. These are the predisposing factors which can give rise to a cecal volvulus. It can also occur if there are adhesions. Sometimes it can occur around adhesions as well. Clinical features are the same. The workup is the same. On an X-ray, you will see the same sign. You will see a coffee bean sign or a bent inner tube sign. The only difference is that apex here, apex of the volvulus will be in the left upper quadrant. Apex of the volvulus will be in the left upper quadrant on X-ray. Whereas in sigmoid volvulus, the apex is towards the right upper quadrant. Okay, so if we look here, in sigmoid volvulus, the apex is towards the right upper quadrant, whereas in cecal volvulus, it will be towards the left upper quadrant. That is how you can differentiate the two. That is the difference which you need to know. Now, the management of cecal volvulus, of course, the investigation of choice is CECT. The management of cecal volvulus, if there is no perforation or strangulation, in sigmoid, you know, we did a sigmoidoscopic decompression. But here, there is no role of colonoscopy. There is no role of colonoscopy. The management is going to be surgery. And the surgery which we carry out can either be cecopexy, we can fix the cecum, or we can do a right hemicolectomy. Or we can carry out a right hemicolectomy. But if there is a perforation or strangulation present, if there is a perforation or strangulation present in the cecum, you know that if the cecum is perforated, this I've covered in the appendix module as well. If the cecum is perforated, then we have to carry out a right hemicolectomy. Then we need to do a right hemicolectomy in these patients. So this is regarding sigmoid volvulus. Sigmoid volvulus, you should also know, is more common in females as compared to males, and it is usually seen in the 4th or the 5th decade of life. Now the final type of volvulus is known as a compound volvulus. Another name for this compound volvulus is ileosigmoid knotting. And this, what happens that if there is a long pelvic mesocolon, that means the sigmoid has a long mesentery, long pelvic mesocolon is there. The ileum rotates around it. Rotates around the sigmoid and gives rise to this knot. Again, this compound volvulus can also be seen if bowel adhesions are there, then also we can see this compound volvulus. Okay. The next cause of dynamic bowel obstruction, we are still talking about dynamic bowel obstruction. The next cause is an intestinal stricture. Another cause of dynamic bowel obstruction are strictures, right? And if you talk about strictures, the two common conditions where we can get intestinal strictures. You can get intestinal strictures in tuberculosis. Another condition which can give rise to strictures is Crohn's disease. Okay. Now, tuberculosis, that when there is intestinal tuberculosis, an ulcer forms, and this is usually in the terminal ileum. That you will have an ulcer forming there. Another thing which you need to know is that what is the difference between a typhoid versus a TB ulcer. This has been asked many times in the exam. So a typhoid ulcer, is going to be a longitudinal ulcer, whereas a TB ulcer is a transverse ulcer. And you need to understand that if you have a transverse ulcer, and if it heals with fibrosis, it is going to form a stricture. So a typhoid ulcer which is longitudinal will usually undergo perforation, and the perforation is usually seen in the 2nd to 3rd week. TB, on the other hand, is a transverse ulcer, and when it heals, it will give rise to a stricture in the terminal ileum. So this is one condition where you can get a stricture. Crohn's disease also, it is an inflammatory bowel disease which I have covered in detail, and you can get a stricture here, and here the stricture can be in any part of the bowel. Right, so these are the two conditions. A patient with a stricture where there is a narrowing, you can see here there is a narrowing or a stricture here, will come with features of obstruction. The clinical features will be of features of obstruction. Now there can be multiple episodes of subacute obstruction, or there can be one acute obstruction episode as well in these patients. Okay. The investigation of choice to pick up a stricture is going to be a CECT. A CECT will pick up that there is a stricture present. Of course, it cannot make out the cause of the stricture. That we will usually get to know once we open up the abdomen. Now let's consider two scenarios, and that will highlight the difference in management as well. So supposing there are two patients, there is patient A who has 3 strictures in 1.5 feet within 1.5 feet of the ileum, 3 strictures, and patient B has 3 strictures, but they are spread apart over 4 feet. Now what will be the difference in management between the two? Of course, both of them require surgery. The management for patient 1, where the 3 strictures are within 1.5 feet, is resection and anastomosis, because I can easily resect 1.5 feet of bowel without any problem, we can carry out resection and anastomosis, right? But if the strictures are far apart, like you can get sometimes in a case of Crohn's, where you can have skip lesions as well. Now the problem is that if I resect 4 feet of bowel, the patient will land up with short bowel syndrome. So I can't resect 4 feet of bowel. So if the strictures are far apart, then we need to do a stricturoplasty. Then we need to carry out a stricturoplasty, and stricturoplasties can be of 2 types. You can either have a Heinke-Mikulitz stricturoplasty. A Heinke-Mikulitz stricturoplasty is that if this is the bowel, I'm going to make a longitudinal incision over the bowel, make a longitudinal incision, but suture it transversely. But we suture it transversely, and this is going to suture it transversely. So the lumen is going to dilate here. Lumen will dilate and the strictured portion will go away. This is Heinke-Mikulitz stricturoplasty. You also have Finney's stricturoplasty, where you take 2 loops, you will take 2 loops and you will anastomose them side to side. So you can see here that a side to side anastomosis has been done, and that will circumvent the stricture which is present there. So these are the 2 types of stricturoplasties, mainly restricted for those conditions where the strictures are spaced apart and resection and anastomosis cannot be done. Another very important cause of bowel obstruction, dynamic bowel obstruction, is Meckel's diverticulum. Let's discuss Meckel's diverticulum in detail. This is a very, very important topic from the point of view of the exam. So Meckel's diverticulum, you know, it is a true diverticulum. It is a true diverticulum. And why is it a true diverticulum? Because all layers of bowel are there. All layers of bowel are present. It is nothing but a remnant of the vitellointestinal duct. Remnant of vitellointestinal duct, and this is seen in the anti-mesenteric border. It is seen in the anti-mesenteric border, and you know that with Meckel's diverticulum there is a rule of 2 which is present here. So the rule of 2 with Meckel's diverticulum, it is seen in 2% population. It is seen in 2% population. It is 2 inches long. It is 2 inches long, and it is situated 2 feet from the ileocecal junction. It is 2 feet proximal to the ileocecal junction. Also 20% of Meckel's diverticulum have heterotopic mucosa, or ectopic mucosa. And the most common ectopic mucosa is gastric mucosa. This has also been asked, which is why there can be bleeding. Most common is gastric mucosa. And the second most common has also been asked in the exam. It is pancreatic epithelium. It is pancreatic epithelium. So this is the rule of 2 which is associated with Meckel's diverticulum. And Meckel's diverticulum, another thing which you need to know, it has an independent blood supply. It has an independent blood supply. And what is the importance of this point, that it has an independent blood supply? That means you can do a diverticulectomy. I can just cut the diverticulum without interfering with the blood supply of the rest of the bowel, without interfering with the rest of the bowel blood supply. Now, what are the various presentations? Each and every presentation has been asked in the exam. So the presentation number 1, you can have an asymptomatic Meckel's. You can have an asymptomatic or an incidentally detected Meckel's. This has been asked many times in the exam. The last one was this year's FMG exam. Also, this question was asked. In fact, the same image was asked in the exam and they'd asked the diagnosis. Now, asymptomatic or incidentally detected, that means you're doing surgery for something else and you pick up a Meckel's diverticulum. Now, how do we take a decision there? If it has a wide mouth, if it has a wide base, then we leave it. We don't do any surgery. But if there is a narrow mouth, narrow mouth or a narrow base, then we will do a diverticulectomy. Then we will carry out a diverticulectomy in these patients. Okay. The second presentation is Meckel's diverticulitis. That means the Meckel's undergoes inflammation, right? It is inflamed. And if you remember the module on appendix, I've told you it can mimic acute appendicitis. It can mimic acute appendicitis. And repeatedly, I have told you that if you get a patient of acute appendicitis, where you open up the abdomen and you see a normal appendix, all of us have gone through this, right? And you see a normal appendix, then you should search the last 2 feet of ileum. You should search the last 2 feet of ileum to look for a Meckel's diverticulitis. And why I can never forget this fact is because there was a similar patient. I was doing an appendicectomy with an intern and the appendix was normal. And I was towards the end of my first year. And I explored the last 2 feet of ileum and I found an inflamed Meckel's diverticulum with an impending perforation there. And I called in my senior resident and I showed him the case, and that was the first time I got to do a resection and anastomosis because the perforation was about to occur. So that is why I never forget this case, and that's why I always keep on repeating that if the appendix is normal, search for the last 2 feet of ileum. Now, if there is a Meckel's diverticulitis, the management is diverticulectomy. If there is a perforated Meckel's diverticulum, then the patient is going to come with peritonitis, and in these patients the management is resection and anastomosis. So diverticulectomy, I've just told you it has an independent blood supply, so you can easily carry out diverticulectomy. So this is the bowel, this is the diverticulum, right? Diverticulectomy is when we just cut this wall and we repair it. Whereas resection and anastomosis, if there is a perforation here, resection and anastomosis would be you cut the entire bowel, here, cut here, and do a resection and anastomosis in this patient. The fourth presentation is a bleeding Meckel's diverticulum. Bleeding is the most common presentation in children. And the reason why bleeding occurs also, I've told you, the reason why bleeding occurs is because of ectopic gastric mucosa. And that is the cause why bleeding occurs in these children. And the clinical features can be either the patient can come with lower GI hemorrhage, or there can be pain associated with it as well. The diagnosis can be made by a technetium 99 per technate scan. This I've also highlighted in where I've covered about lower GI hemorrhage, that this is the most sensitive investigation. To pick up bleeding, and it can pick up bleeding as little as 0.1 ml per second. It is very sensitive to pick up bleeds. Now, management of these patients, majority of the times it is a self-limiting bleed. But if it persists or if it recurs, then we need to carry out, we can either carry out embolization, but the definitive treatment in this case, is going to be a diverticulectomy. Now, the final manifestation or the penultimate manifestation is that Meckel's can be part of a hernial sac, and this has also been asked multiple times. Such a hernia is known as a Litter's hernia. Such a hernia is known as a Litter's hernia. This has been asked multiple times. And the final presentation is that it can give rise to bowel obstruction. It can give rise to bowel obstruction. Bowel obstruction is the most common presentation in adults. This you should know. This has been asked in the exam. So it is the most common presentation in adults, and it can give rise to obstruction in two ways. So the most common way how Meckel's can give rise to bowel obstruction is it can act as a lead point for intussusception. I've already explained to you what lead points are, and it can act as a lead point for intussusception. This is the most common. And another cause is that this is the Meckel's. Sometimes a fibrous band goes from the Meckel's. You can have a fibrous band going from the Meckel's to the umbilicus, and the Meckel's can undergo volvulus around this band. It can rotate around this band. It can undergo volvulus around this band. That is another cause, but the most common is that it can give rise to intussusception. Right. So this was Meckel's diverticulum, which was another cause of dynamic bowel obstruction. The final cause of dynamic bowel obstruction which we need to talk about is superior mesenteric artery syndrome. Now, superior mesenteric artery syndrome, another name for this is Wilkie's syndrome, also known as cast syndrome, So first let's understand the anatomy, and then let's understand why is the syndrome developing. So the normal anatomy, this one here is the aorta, right? This is the aorta, and this is the superior mesenteric artery which is being given off, right? Now, the superior mesenteric artery and the aorta, this is the angle which is there, and the angle, the normal angle between superior mesenteric artery and aorta is around 25 to 45 degrees. Is around 25 to 45 degrees. And how is this angle maintained? Angle is maintained due to a pad of fat. Due to a fat pad. You can see this fat which is there is the one which is responsible for maintaining this angle. And another thing which you need to remember, that it is the third part of duodenum. This is D3 which is lying in this angle. Third part of duodenum is lying in this angle. Now, any cause, if the angle reduces, that means the angle becomes less than 20 to 22 degrees. If the angle becomes less than 20 to 22 degrees, then D3, third part of duodenum, gets compressed. Then the third part of duodenum, this was asked in the AIIMS exam, the third part of duodenum gets compressed. Now, why will the angle reduce? The angle will reduce if the fat pad is lost. If the fat pad is lost, that is when the angle is going to reduce, and this can be seen in patients with anorexia, or if there is rapid weight loss, or if there is a spinal cast which is put. These are the conditions when this fat pad can go and the angle can reduce, and these patients can land up with duodenal obstruction. The clinical features would be bilious vomiting. There would be weight loss in these patients. And the investigation of choice would be a CT angiography. So when you'll do a CECT, you'll know that there is duodenal obstruction. And when you do the CT angio, that's when you'll get to know that the angle is compromised or the angle has become narrow. Now, how do we manage these patients? The management of these patients is we ask them to gain weight. If there is weight gain, the fat pad can come back again. So these patients can initially be given TPN. You know, TPN is total parenteral nutrition. Then they can be shifted to enteral nutrition, right? Initially we need to give TPN because Initially, they'll keep on vomiting everything. So you first give TPN, and when the vomiting stops, then you shift them to enteral nutrition. Another procedure is strong procedure. Strong procedure is, this was also asked in the AIIMS exam. This is duodenal derotation procedure. This is duodenal derotation procedure. In this, we cut the ligament of Treats. We cut the ligament of Treats in this. That is duodenal derotation procedure. This can also help. And the final resort, if none of this helps, the final thing which can be done is a duodenojejunectomy. The final thing which can be done is a duodenojejunectomy. Now, if you remember, I told you for duodenal atresia for annular pancreas, we were preferring duodenostomy, but in superior mesenteric artery syndrome, we prefer a duodenojejunectomy. So this was the final dynamic bowel obstruction which you should know about.